Um, so it's 11 o'clock. We've got a few attendees joining us, so I'm going to go ahead and kick us off. Hello and welcome everyone to the Stimulant Use Disorder Practice Update Rural webinar hosted by the BC Centre on Substance Use. My name is Rebecca Anthony. I'm the Program Manager for the Education Implementation Team with the BC Centre on Substance Use, and I'll be moderating today's webinar. The purpose of today's webinar is to introduce the recently published Stimulant Use Disorder Practice Update and provide an opportunity for a discussion and question and answer period that focuses on rural and remote contexts. Just a couple of housekeeping pieces before we kick off here. This webinar will be recorded for later viewing. If you have any questions, please enter them into the Q&A tab rather than into the chat. In the Q&A tab, you can like other people's questions and upvote them, and we'll address them in the Q&A portion of the webinar today. And before we start, I'd like to acknowledge that the BCCSU is headquartered on the unceded and traditional territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations, and that I personally am calling in today from the traditional homelands of the Squamish, Stlali, and Lil'wat peoples. And then I'd like to introduce our speakers. I'm very privileged to share a screen today with a fantastic group of speakers, and I'd like to give everyone the opportunity to introduce themselves and say a little bit about themselves today. Why don't you start us off, Dr. Rook?
Oh, thank you. So hi, everyone. Welcome. I go by Eddie Rook. I was born on Treaty 6 territory and have been spending the last 4 years in the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations based out of Vancouver. My background is white European, English on my father's side and Irish on my mother's. And I come to this because one of my other roles I play is I'm a co-lead for the First Nations Health Authority Physician Addictions team. And our service exists to support Indigenous clients all over the province. And I would say about 80% of those engaged in our services live in rural communities and small to medium-sized towns. And so in a way, I'm working in a number of rural contexts and need to understand and work with local partners as much as possible. So I'm very pleased to be here. Thanks, everyone.
We're very happy to have you. Kat, would you like to go ahead and introduce yourself?
Yes, so my name is Kat Kiju. I come here with a person of lived experience, and I am calling in from the traditional territories of Lheidli-T'enneh, which is colonially known as Prince George. And I'll be coming here bringing my lived experience and speaking for people with living experience as well, as a whole. Thank you.
Thanks, Kat. And we can pass it over to Dr. Bach.
Thanks. Hi, everyone. My name is Paxton Bach. I'm calling in from the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. And I am an addiction physician here in Vancouver. I work at St. Paul's Hospital and am additionally the co-medical director for the BC Centre on Substance Use. I'm here as one of the authors of this Stimulant Use Disorder update, which was a collective effort from prescribers around the province. And I'm here to help deliver some of the content. I acknowledge that I do work in a very urban setting with a pretty urban population. So I'm very happy to share the screen with these excellent colleagues who will help to provide that rural context and hopefully speak to the prescribers or to all the attendees who are on this call. And I'm here to also learn a little bit about the barriers that are faced in settings different from the one that I practice in, just to hear about how we can make sure that our guidance speaks to everyone across the province.
Excellent. Thank you, Dr. Bach. And Sherelle.
Hi there. My name is Sherelle Leckie. I am here to talk about, I guess, lived experience. I am calling in from Kitimat, BC. I recently relocated here from Prince George, where I lived there for 23 years, but 5 of those most recently were on the street as a homeless person. And it was in there that I ended up struggling greatly with addiction, in particular opioids and crystal meth. And I'm here to talk about my lived experience and success with the stimulant use prescriptions that I was able to receive when COVID hit and up until now. that's what I'm here for. So thank you.
Excellent. Thank you so much for that introduction. And we are very grateful to have everyone here participating today to share their knowledge and experience with the group. With that, I'll pass it over to Dr. Bach, to go ahead and start our presentation.
Okay, thanks. So as mentioned, I'm here to at least for the first half of the session, kind of walk everyone through the practice update, which was just issued. We'll go through sort of an overview, and I'll open the floor to my colleagues to comment as we're working our way through the document. And hopefully that leaves us a significant amount of time at the end of the session to talk about rural perspectives and Q&A from the audience. So this is the practice update, which I hope many people have had a chance to page through. It is, as mentioned, it was a collective effort from prescribers from around the province. It's not meant to be a guideline, a robust a summary of all of the evidence, but more an update on some current trends and current practice patterns in the management of stimulant use disorder. I'll walk through the background here, which again I don't think is news to anyone, but as we're all probably well aware, stimulants are among the most common illicit psychoactive substances used around the world, and same goes for British Columbia. For the purposes of this talk, stimulants spans everything from caffeine to cocaine to bath salts. We'll be talking primarily about cocaine and crystal methamphetamine for the purposes of today's talk, and that's what this guidance is speaking to. It's really just important to note that stimulants are increasingly detected in illicit drug toxicity deaths, both in BC as well as across North America. Their co-use with opioids, in particular with fentanyl, is becoming increasingly common and has been termed by some as the fourth wave of our overdose crisis. While polysubstance use is becoming an increasingly commonly seen pattern, there's also the risk of fentanyl contamination and inadvertent exposure to fentanyl for those who primarily use stimulants, which is unfortunately becoming all too common in our province as well. So as mentioned, the stimulant use disorder practice update is really divided into two sections. The first is a more of a review and summary of current evidence-based treatment options and some recent literature in this area. And the second part is more focused on prescription psychostimulants or risk mitigation prescribing and experiences. What data we have to support this practice or to inform this practice, and both clinical as well as patient perspectives on risk mitigation prescribing. So I will dive then into part one, and we'll review the current treatment options for stimulant use disorder. Just to begin here, reviewing acute stimulant intoxication itself. So acute stimulant intoxication is a pretty characteristic presentation, seen commonly in emergency rooms across Canada, increasingly commonly, and is characterized by all of these the sympathetic nervous system sort of overdrive, agitation, sweating, abnormal movement, hypertension, paranoia are all symptoms of pretty significant stimulant intoxication. The use of stimulants, it varies from alertness and euphoria and increased concentration all the way to all-out psychosis. These are some of the more common presentations that we might see when somebody presents to the emergency room. And for the purposes of this document, we're really distinguishing acute stimulant intoxication as a presentation to emerge. Sometimes termed overamping would be another definition, or another term that's used sort of colloquially. We're trying to distinguish that from the frank psychosis and loss of insight that can be seen in more extreme cases. The reason being that for acute stimulant intoxication itself, for that agitation, hypertension, anxiety that we may typically see presenting in the emergency room, the mainstay of treatment for that really is supportive. It's conservative management. It's a quiet setting. It's a low stimulation environment. A warm blanket or a cold glass of water. Low lights. Avoiding stimulation, just giving people kind of a safe space to feel comfortable and just come down off the stimulants is really the recommended treatment. Benzodiazepines used PRN is certainly reasonable in those situations, but that does differ significantly from those who are presenting with frank psychosis. This is something that we've talked a lot around with some of the psychiatrists in the province, and really. I think it's a little artificial to describe these as two completely distinct presentations. Certainly, it's a bit of a spectrum, but psychosis is really characterized by that extreme agitation, that loss of insight, delusions and hallucinations, really a loss of awareness as to what's going on. That's a different presentation than intoxication is in general, and one where the management may become a little bit more complicated. So for the purposes of this document, because of the nuance involved in these more extreme presentations, we've really strongly recommended in these cases to either involve your local psychiatrist if you have that option in your emergency room at your hospital, or if not, calling the 24/7 line for a discussion of these more complex cases and when you might or might not need to reach for things like antipsychotics. But certainly these are more complex cases and often may involve more follow-up. So we've really focused on the intoxication itself as the area where we're focusing our guidance on for this document. Just to this end, I'll open the floor here to either Eddie or either of our panelists with living experience. If there's anything you want to comment around stimulant intoxication, overamping, or psychosis itself.
Yeah, it's Kat here. I'd love to make a few comments. I'd highly suggest, and I'll say this anywhere I can, is it'd be really beneficial if there was some way to have access to some peer support, especially if that's available, and somebody comes in who is in a state of psychosis. I think it's really important to understand their psychosis is very, very real to them. A lot of times psychosis leads to like a fear. So making them feel safe, talking them through it, absolutely a calm space, like a warm blanket is absolutely what needs to happen. They need to know that they're okay. They need to know that they're going to pick up on any type of discrimination or stigma or feel of like, we don't want to deal with you, you're annoying us. That's only going to heighten their psychosis or their agitation or freak out, whatever it is. I think it's also really important to understand that if they see a pink elephant in the room, and this is just a metaphor, that they see a pink elephant in the room and to acknowledge that and talk them through it. Because that again is going to try and build a little bit of that connection and a way of being able to get through them and calm them down. Yeah, that was my 2 cents.
And those are really, really excellent points, Kat, and especially that idea of peer support that's available, I think is so invaluable. But really the key word I'm hearing from you is safety. And people have to feel like they're in a safe space. If we're not making that space feel safe, then the situation could escalate.
Yeah, and last thing you want is for them to leave. Right. And if they're feeling like they're being locked up, if they're being, just shoved into another room, or if they see security guards, all these things need to be looked into consideration on how this person is being approached. It needs to be treated like any other medical concern would be treated if somebody is going through a traumatic event, with compassion and care.
Hi, I've also got something quick to add as well. Is that, like, you're talking about this being in an ER setting, right? So I'm seeing that, like, in this case, this is a potential where there's a lot of overdose people, where the people are coming in, and I think that there should be. It is at least in my knowledge, like with Prince George, it is very often that you're going to get opioids and crystal meth mixed together. So you're going to get people who come in with overdoses, and the Narcan will go and target the opioid, right? And it'll negate that, but then all of a sudden they're high from the crystal meth becomes more prevalent, and that's where you're going to get also a lot more agitation that may not be recognized, and you get that panicked reaction and stuff. It's just something to take into consideration, that the people that are reacting quite, like, you with the extreme agitation, anxiety usually is going to be something with crystal meth, and having those, I was never presented with having any kind of like diazepam or anything like that as an option in order to help me come down, or knowing of anybody having that option. So having that, knowing that that's there is something that should be maybe a little bit more, given a little bit more exposure.
Thanks,
Thanks for that.
everybody.
Go ahead, Reddy.
To just add a perspective, I'm seeing people in the community that are frequently coming in with various mental health manifestations of stimulant use. And just like Kat has said, you know, it's a very stressful, real situation for the client, and acknowledging the stress, trying to find a way to help, creating a safe space physically and mentally and culturally is so important. And, you know, you might hear a client saying all sorts of like what they're going through, and they're trying to explain it, and then they're looking for understanding, and listening and acknowledging someone's stress, not challenging. If your reality is different than what they're experiencing, you don't need to confront that. You can acknowledge the stress, and you can try to plan and try to find ways that you might be able to improve the situation. Sometimes people just need to be heard and have some follow-up arranged. And peer support, fantastic.
Yeah, all really excellent points. Thank you everyone for that. Just to, you know, on this note of stimulant-induced psychosis, this is unfortunately a relatively common presentation for crystal meth intoxication. We know that there are links with persistent psychotic symptoms, including schizophrenia and bipolar disorder, but it is quite complex, both in terms of teasing out the difference between a stimulant-induced psychosis and an underlying primary psychosis. The management there is also endlessly complicated. So again, considering consultation with psychiatry, if it's available, is really strongly recommended. Just the flip side of that I'll touch on, and we'll touch on this briefly because I think this is probably not news to much of the audience, but just a reminder that stimulant withdrawal is also a very real phenomenon as well. Oftentimes we think of withdrawal from substances like opioids or alcohol, which is, you know, obviously pretty dramatic and potentially life-threatening. But stimulant withdrawal is more subtle, but can be very incapacitating as well. That depressed mood, fatigue, anhedonia, pain and anxiety, either hypersomnia or insomnia are all pretty characteristic traits of stimulant withdrawal. And this can last for, you know, certainly the crash can last for 2 or 3 days, but many of these symptoms can linger for weeks and can be very, very frustrating. And so again, no specific management recommended for these, but I think a validation of them is really important. And just a recognition that these things exist, and that every day should be a little bit better than the last. Again, Kat and Cheryl, if you guys want to chime in here at all, what your experience is.
Cheryl, do you want to go first, or do you want me to go first? I went first last time, so I'm just opening the floor.
Oh, it's okay. You go ahead.
Okay. So yeah, I think it's also like there's a lot of different withdrawal symptoms when it comes from withdrawing from crystal meth. I think it's important to understand that it's almost as bad as opiate withdrawal. Like, you go through pain. If they're saying they're going through pain, they're going through pain. For myself, it really hit my back, and that was like the worst part that hit was for my back. The agitation, the sore muscles, like it's you know, the sweats. There's a lot of similar symptoms to opiates. So I think it's really, yes, important to acknowledge that they're going through that, but also trying to see how you can offer something to help go through it. Like, you know, looking at the safer supply, and, you know, the Ritalin or the Dexedrine, and then maybe, you know, something else to help with like the other symptoms that they're going through. I also think it's really important to understand, like Cheryl said earlier, a lot of people that use crystal meth also use opiates. And then a lot of the toxic drugs have benzodiazepines in them, which withdrawal from those is really bad. I mean, it coming out of that, almost like you go through almost like a state of psychosis, like you start seeing things. It can get that bad. I've seen people freak out and seeing, you know, things from coming off of it. And it's, I just think, again, really acknowledging and hearing what they're going through and trying to work with them instead of approaching it with, I know what you need. It's, what do you need? Or what do you think will work for you?
Yeah, I'd like to chime in here actually with the benzos. Like I've been gone from PG now for like almost 6 months, but I know in the previous 6 months that I was there before I left, benzos were extremely prevalent in the opioids. There was a lot of them in there, and I think that that's becoming an unacknowledged dependence that a lot of people are not aware of, that because they're being slipped into the drug so much that there are people now that are presenting with withdrawal symptoms from benzos that they're not even aware of, and that maybe the community, like the health community, isn't aware of as well. And that's something yeah, it's definitely a good thing to be brought up. But what I wanted to come in with the withdrawals of the stimulants just quickly was that I didn't actually have to go through too many of them because I was able to go from crystal meth to the stimulant use, and I was able to use methylphenidate in order to mitigate those symptoms. And so that was one of the big pluses for me of the program, was that I was able to get off of crystal meth because of that.
Thanks, Cheryl. I think we could do a whole different talk on benzos, and it's causing problems for all of us. But that's a good kind of preview of the second half of this, where we'll talk a little bit more about the methylphenidate and dextrin. Just to complete this section, talking about so again, stimulant withdrawal, no specific treatments, but supportive care, and above all, just a recognition that this exists and it can be quite debilitating. As far as treatment options go, just to finish out this part one where we're talking about treatment of use disorder itself, just highlight that the evidence around pharmacotherapy about medications for the treatment of stimulant use disorders is fairly limited and inconclusive. And again, we're speaking here about evidence-based treatment, but there is limited signals of efficacy in the literature. To talk a little bit more about psychostimulants as well as a number of other medications. I won't dwell too much on this literature right now. I'm more than happy to chat about this at length if anyone ever calls me on 24/7. But I just want to highlight some of the considerations when we talk about the literature around stimulant use disorder, because it's often summarized as we don't have any effective medications, and I think that's a little bit of a crude interpretation. There are many. There's at least 30 RCTs out there looking at treatments for cocaine use disorder and for methamphetamine use disorder. And so when we don't see consistent signals of benefit, often people get pretty cynical about the likelihood that we're going to develop medications for this treatment. I just want to highlight some of the reasons why this literature is so hard to interpret, though. And despite the number of trials, they're very limited by a number of things, including really strict primary outcomes. Almost all of our trials have targeted abstinence as an outcome, which may not be the most realistic or patient-centered goal as a primary outcome. They often have very limited power. They've all been relatively small trials, and the participant dropout in these trials is really high as well. It's often around in the range of 40% participant. So when you have a trial with limited power and that much dropout, the likelihood of obtaining any kind of positive signal out of it is dramatically decreased. There's high rates of placebo responses and often poor adherence to medication treatment in the trials as well. So, I don't want to dwell on this other than just to highlight that while this literature often gets summarized as the fact we don't have any effective treatments, I think that is a crude interpretation, and it's really difficult for us to draw conclusions from a lot of this literature one way or the other. I'm not going to spend much time talking about these particular papers, but again, for the purposes of crystal meth treatment, which is by far the most common stimulant that I'm seeing and these days, and I think in most places in the province in the last at least 5 years, there have been several new studies that have highlighted some medications again that are worth considering. These are three relatively recent, relatively prominent studies that I've put here just so people can look back at them if they want after the fact. Just to highlight the take-home messages here is that these are all studies that have looked at abstinence as a primary outcome, which is again is a high bar to set, and have actually found are well-conducted trials which have found significant benefit to certain medications for the treatment of stimulant use disorder. So top left was a trial done in San Francisco 4 years ago, where they found mirtazapine was effective for crystal meth use disorder amongst a population primarily of men who have sex with men, with a number needed to treat of 10. In the top right, there's a meta-analysis here looking at psychostimulants for the treatment of stimulant use disorder as a whole, including cocaine and crystal meth, but again, found a number needed to treat there for abstinence of 16 and using psychostimulants, which again, abstinence may not be the goal for everybody. And the bottom left is the ADAPT-2 trial, which came out a little over a year ago now, showing that a combination of bupropion and extended release naltrexone was quite effective in a population of people who use crystal meth for achieving abstinence. Obviously, extended release naltrexone is not an option for us in Canada, but these are just to highlight the fact that there has been recent literature that's suggested that has had more positive signals for the treatment of crystal meth use disorder, and that even when we are setting abstinences a bar, there are medications out there that are safe and maybe worth considering. If these aren't medications you're familiar with, again, calling race or speaking with 24/7 is highly encouraged. But these are relatively easy medications to trial if you are in a setting where you're wanting to trial some pharmacotherapy for somebody with stimulant use disorder. I'll open the floor for comments from the rest of our panelists, but I'll just flip through the rest of this. Is that I can't highlight enough that the most evidence-based treatment that we have for stimulant use disorder remains psychosocial treatments, though. And there are a variety out there. They are the standard of care for stimulant use disorder. I'm sure you've all heard of contingency management in particular as by far the most evidence-based treatment we have for stimulant use disorder. Number needed to treat in the range of 4 for contingency management programs. But I also recognize that even in Vancouver, even right in the downtown, these can be incredibly difficult to access. And so, depending on where you're working in rural settings, oftentimes we may have to be a bit more creative in trying to access these programs. I think Eddie can speak to this a little bit. There's a variety of other psychosocial treatment programs out there, including CBT, matrix, peer-led support groups, and bed-based treatment programs where the evidence is quite mixed. I'm not going to, for time, I won't get into the evidence around each of these treatments. But contingency management is certainly the gold standard if it is available to you. Talk a little. Well, before we get to this, I'll just see if any other comments from the panelists around pharmacologic or psychosocial treatments.
I would just add that thanks for acknowledging the difficulty in accessing some of these programs. And I know depending on the center you're in, they can seem almost impossible. In the last few months, contingency management being such a useful program and the most evidence-based, our First Nations Health Authority virtual program we're working on creating our own virtually, centered in different regions of the province. And my clinic in the downtown east side is also developing one that is also partnered with CBT at the same time. So we're hoping to increase the capacity of those kinds of programs, but it'd be quite challenging to access them.
Yeah, I guess for getting people to understand that this is available, like for me, I'm only coming from the point of having methylphenidate and dexedrine available as an alternative. For me, it was, as I mentioned earlier, like it was when COVID hit and we were having to be self-isolated, and we were being provided options in order to manage our withdrawals. That was never really a focus. It was only the focus was on the opioids, right? And the ability to have a pharmacological option wasn't readily presented, and I don't know how to get that out there as an option. And that was one of the things that I know that really it's word of mouth between the other addicts. That was the one way that I found, like in Prince George, when I talked about the fact that I was able to get a prescription, I was always getting a lot of like, really? Wow, how did you get that? And it would be by word of mouth that like I managed to push it and get lots of other people onto it. But I don't know, like that's a border that, or a boundary, or whatever it is, the word I'm looking for, but that needs to be overcome, is to get it out there that it is an available option.
I hope that's what we're doing right now, Cheryl. So.
I just want to make some comments. I think it's important to recognize, the challenges, especially in more rural or remote settings, and the frame of mind of like having them to be or expecting them to be completely abstinent is already a fail. I think you need to work with the person and not set expectations for them. And in a more rural and remote setting, understanding that they might not be able to go in every day or once a week, or I mean, like a lot of people travel 2, 3, 4 or more hours just to try and hit a hub or somewhere else, because a lot of more there's a lot of stigma in rural remote settings. So just to reach out, they might have to go to a different community, and keep it really hush hush. So I think that they really need a lot of support and understanding that, there's a lot of barriers with rural remote settings getting access to any type of like stimulant therapy or opiate therapy. And another thing I noticed was a lot of people who were trying to seek the stimulant had to be using opiates in order to get the stimulants. And that puts people at risk, where people did actually use opiates to have it in their system so that they were able to get a stimulant maintenance, which makes it kind of defeats the purpose because you're opening up another door. So just wanted to say that.
Yeah, I would agree. Oh, sorry, go ahead. I was going to just say I agree strongly with the latter half what you're saying there, and thanks for highlighting some of those rural barriers, Kat, and hopefully we can explore those a little bit more in the Q&A.
Yeah, that was something, what you touched on with people going and taking opioids in order to get access. That's one of the things that I noticed. I know that this is stimulant use, but like I know that was one of the big problems is that once we got on Dilaudid, we couldn't go into the detox centers in order to get off of those. We actually had to go back onto heroin in order to be allowed to get into the detox to get off of them. And I don't know if there's any availability to go into the detox just to get off of crystal meth or to get off of, say, the methylphenidate or the dexedrine option. I'm not sure. And also the stigma too. One of the things that I think that we deal with as well is that when we're going through those, we want to go into abstinence and go onto Dilaudid and go onto methylphenidate. We're also going through the stigma of having to go every day to the pharmacy and having to have people look at us and know that that's what we're doing, right? Because we have to go, a lot of us have to witness and stuff like that. And I don't know if that's so much the case because of the methylphenidate. It's not a triplicate, but it's still something that like even now I'm down to like every 2 days where I go, which is a great thing. Like I don't feel like I'm being looked at, but it is something that should be like kind of addressed as something that we do have to go through.
Lots of
sorry.
Absolutely, Kat, go ahead.
I just back on like that frame of like being like expecting to be abstinent based. And again, like I think really having to work with the person and if that abstinent is their goal, maybe understanding that, maybe for the first bit, they're going to see dirty urines because it's a phase of going from toxic street drugs to being stable on like methylphenidate or something. It's setting them up again almost for failure because you're going through withdrawal of other things. So it's like a way of them. It's almost like I had to microdose. So mine was like a microdose stage, like build up with the methylphenidate, slow down on the crystal meth until I was like, able to just stay on the methylphenidate. So I just wanted to point that out too.
That's really interesting to hear your experiences and actually kind of adjusting these medications and I'm going to breeze through the second half of this, which is just an outline around the prescribing of that. I'll go rather quickly to leave more time for this discussion because I think that those stories you're telling, Cheryl and Kat, are really really interesting and worth focusing on. This is just a slide to remind everyone that whatever substance somebody's using and whatever their goals are, that counseling on harm reduction and safer use strategies is always a critical component of any interaction. So I'll review this section a little bit quicker because I'm really curious to hear those lived experiences from both of you in accessing these medications. But part 2 of this document is around the use of prescription stimulants to reduce overdose risk and other harms. And when we're talking about prescription psychostimulants for the purposes of this document, it's really focused on methylphenidate or Ritalin and dextroamphetamine or dexedrine. It sounds like you guys have some experience with both of those. So I'll highlight that the latter half of this document is really focused on a harm reduction approach to the use of these medications, and we're not really talking about it in a treatment framework per se. The evidence base here again is not nothing, but it's quite mixed. But I think that we're focused on individual stories and goals. This is that meta-analysis that I did allude to in the first half, just showing that psychostimulants, when pulling across many studies, psychostimulants were effective at promoting sustained abstinence from illicit stimulants, which again is a pretty high bar to set, but that the majority of the studies included in this were focused on cocaine use. So really, as for the purposes of amphetamine and crystal meth use, we're still operating in somewhat of an evidence-free area. I would say that clinical experience, and Eddie may speak to his, but clinical experience in my world have found that prescription stimulant medications have had a limited benefit for people who use illicit substances. I've certainly seen a significant number of people who haven't found them particularly helpful, but I think that we've all heard stories from those who found them extremely helpful, depending on what it is that they were trying to accomplish. And we have some of those stories here with us today. And some have reported significant reductions in the use, or significantly safer use, or just overall improved functional or social outcomes from these medications. So based on the limited signals of efficacy in literature, as well as those stories, that is what's led for us to develop this framework. But as highlighted, a thorough risk-benefit analysis and exploration of goals should guide all clinical decision-making due to the potential harm that these medications might cause, and sort of some of the unknowns that still exist when we're operating in an evidence-free kind of area. The overdose criteria, or the eligibility criteria, has not changed since the original risk mitigation document. Ongoing active stimulant use and risk of overdose or other harms related to illicit stimulant use, which I think is pretty broadly encompassing in the current era. I would say anyone who's using stimulants is at risk of overdose these days. So this really captures just about anybody. There's some details here provided around recommended assessments, and much of this is pretty consistent with your traditional addiction medicine assessment, a thorough biopsychosocial assessment. The pieces that I have bolded here, just for the purposes of, I wanted to really emphasize that I found particularly useful and important when doing these assessments, is talking about, as both Kat and Sherelle have alluded to, is goals of the patient. What are we trying to accomplish in starting these medications? Because abstinence may be the goal for some people, but many times that may not, or it may not be the most immediate goal. And another thing that I found just particularly helpful to talk about up front, and I'm curious for the input of other panelists, is sorting out up front how we're going to decide together if these medications are helping somebody. And that's really tightly linked to what their goals are, because it may not be abstinence, it may not be urine drug screens that are negative from substances. It may be reported reductions in use, it may be reported safer use, or it may be improvement in other quality of life areas in terms of mental health, physical health, financial health. So figuring out upfront how we're going to assess benefit, I think, is really helpful when you're checking in along the way to see, are these medications helping? Are they not helping? Should we continue them? Should we try something different? Really like setting those goals up front, but being flexible in them, I think, is a practical tip that I can provide. Well, we can talk further about cautions, but I think that anyone with a history of psychosis or of significant mental health diagnoses, it's something to explore. There's no easy way to approach patients who have this kind of history, because certainly there is a risk then in high dose psychostimulants at potentially exacerbating these conditions. But if these medications do help them reduce their crystal meth use or illicit stimulant use, then there's certainly a risk benefit discussion to be had. And I think that, Eddie and I've talked about this a little bit. There's no easy answer to how to approach these conversations. I would suggest that this is not an absolute contraindication, and it's really a discussion with a patient. Ideally, if they do have a mental health team involving in that discussion as well, talking about the risks, the benefits, the unknowns, and how we're going to proceed together. I think involving everyone in those conversations is key, because there's nothing that's black or white here. Similarly, if you do end up with patients who are pregnant, I would strongly suggest calling the race line or the 24/7 line.
Really
and
well
I'm just
said.
going to go.
I completely agree with what you're saying, Paxton, about just being flexible, exploring it, trying to involve mental health teams and peers, and just really understanding what the client's goals are and what they're ready to try.
I'm going rather fast through these details because I want to open the floor to Kat and Sherelle to comment on the section as a whole. So I'll just finish out some of the clinical details. The contraindications as per the labels of these medications do include significant a history of coronary disease or structural heart disease, as well as mentioned, significant history of past mental health diagnoses. I think all of these are relative contraindications, so things to consider. And again, if you have questions involving other experts, whether it's internal medicine, cardiology, addiction medicine, or the mental health teams, peers, involving as many parts of a patient network as you can to make these decisions, I think just helps us make more informed, collaborative decisions. This is the recommended dosing. There's a lot of a lot of flexibility here and a lot of variance that you see in practice patterns. For dextroamphetamine, generally starting somewhere in the range of 10 to 20 milligrams BID has been recommended, with a total maximum daily dose of 40 milligrams BID is the highest dose that we can document a relatively good safety profile for. Anything higher than that is sort of the unknown. In my experience, combinations of sustained release and immediate release can, I really talk to a patient about what their preference would be between one or the other, or a combination of the two. And I'll just highlight that the best literature that we have does suggest doses higher than 60 milligrams or 30 BID are going to be more likely to be effective. Similarly for methylphenidate, starting off 20 to 40 milligrams once daily with a maximum total daily dose of 100 milligrams. Again, potentially sustained release or combination of SR and IR. There's zero evidence to guide us in the dosing here, and so it's really very much a collaborative and kind of iterative discussion with the patient. You figure out what works for you. I don't know how much tinkering Sherelle and Kat have done. So again, we'll open it up to their stories. But this is just a reiteration of, again, patient preference in terms of both slow release and or immediate release is one thing to emphasize. Frequency of dispensation is really guided by clinical judgment. Oftentimes we are recommending daily dispensing as far as the guidelines go, because they are still within this the sort of traditional addiction medicine framework, but I absolutely opportunity for clinical judgment there, particularly again for an audience such as this one, where we're operating in a rural setting, and there are very, very significant barriers that have been highlighted by Kat, both in terms of stigma as well as just geographical limitations. Those are really important to consider, and there's lots of opportunity for clinical judgment here. I think this is the last slide, or the last couple of slides. I'll go through this, and then I'll open it up to Sherelle and Kat. But if a decision is made between a prescriber and a patient to trial these medications, that I think one of the most critical parts of this is just regular and close follow-up to adjust dosing, to adjust formulations, to assess goals. Initial trial period may be as short as 1 to 2 weeks, followed by a thorough assessment of how things are going, and revisiting those goals that you've hopefully set together up front, seeing how we're progressing. And if there isn't the benefit that's being seen, figuring out is that a medication selection issue, is that a dosing issue, or perhaps a medication is not the right approach for an individual patient, because certainly not everyone has found benefit from these medications, and discontinuing them and going in a different direction is a totally reasonable approach to it if they're not benefiting. And again, benefit is an umbrella term, and that can have, there can be many signs of benefit beyond just reduction or cessation of illicit stimulant use. So keeping a broad perspective on what benefit means, I think, is important. This is the one last plug then here is just a reiteration that for any of our safer alternative prescribing or risk mitigation prescribing, to denote SA on your scripts for safer alternative, and that's specifically for tracking purposes for the evaluation of the effectiveness of these programs. There is a provincial evaluation program underway, so that is very helpful if you write SA on the scripts so that we can, for evaluation purposes. Here is the number from the 24/7 line, which is available 24/7 if anyone has ever has questions around the medications. So with that, I'm just going to pause here because I've gone through a lot of clinical content here, but I want to give Sherelle and Kat the opportunity to provide their input based on whether they agree or disagree with what I'm saying here, but also your own stories and experiences with these medications and messages that you would like to deliver to this audience.
Sure, I'll go first. Yeah, absolutely. I agree. I think the support system is huge. I think if you have access to some peer support, mental health, whatever that looks like, housing, income assistance, I mean, offering a prescription is one piece of a big pie. And you need to look at what all those pies are that need to be filled and how you can connect them as a whole with that support system. Because just offering an alternative medication and expecting that to help everything is unrealistic. And then I think for like looking in terms of risks, or honestly, it's talking to the person, if asking them again, like I said earlier, what do they think is going to work for them? The combination, I had to use the combination, and it could be just I had the Ritalin, and that was more of like a fast release, and then I had the slow release. And I actually had a great relationship with my prescriber where I was able to take as needed. I wasn't like, you can only take this time. And there was none of that. It was like, she trusted me. They worked together. And that's what worked for me. I didn't have to go in and pick up, so much every day. It was, I got a bottle, and this is, this is what lasted me for the day. If it lasted me for 3 days, that was okay. It wasn't, oh, you're cut off right away because you missed a day or 2 days. We really worked together, and I think that's the key piece there. And like, yeah, and trying different things. Like, absolutely, if one doesn't work, then trying and seeing what they think. Again, like working until you find something that's going to start working for them, or if they start seeing a bit of a difference. And I also think that it is really important to, again, get rid of that abstinent based, unless that is their goal, and asking them, okay, how do you want to get there, and how can we help you get there? And if it's not abstinent, and it's to, not have to pull 10 dates a day, and you want to come down to maybe pulling 2, that's a huge improvement of quality of life, and like wholehearted, like, emotionally, spiritually, mentally, physically, and all within the medicine wheel. So holistically, or doing crime, or just wanting to try and cut it down to $40 a day type of thing. That's huge. That is huge. But again, like, how do you get there, and how do we connect when you get there? So those are my comments. Go ahead, Cheryl.
Okay, yeah. I guess I had a really good relationship with my prescriber as well. That was one of the things that I think that made the biggest difference was that at first when I was put onto the prescriptions, it was sort of like just a go update your prescription at the needle exchange kind of relationship. And there was no real bond with my prescriber at the time. And then there was a great big push in the medical community in order to put the patients back with their doctors. And I was lucky enough to stay with that same prescriber as she was my regular doctor, but having discussions about what my goals were a huge thing. Like she knew that I wanted to eventually get off of everything. And that's what we ended up kind of doing, like not quite microdosing. It was more on me to do it. But I eventually became where I have been able to be off of street drugs now for about 8 months completely. And I am actually just on the pharmaceuticals. And it was having that relationship that made it was crucial, like having to being able to discuss things with her was, but I think that focusing a little bit more on what the symptoms are of withdrawal and what to expect from doing both at the same time, because I believe in the initial stages, I was on almost an overdose constantly because I was using crystal meth and methylphenidate at the same time, and we hadn't had that discussion. And so I might have hit onto psychosis a few times and not realized it. And because there was no discussion of that happening, and that may be something to just keep in mind. And I think that was pretty much what I had to say, just that, like, I mean, really, I have had great success with it. Like to be able to only be on methylphenidate now is incredible for me, rather than just having crystal meth and Dilaudid as well too. I've had great success, and I would be probably the only one person in the world that would say thank goodness for COVID, because COVID allowed safe supply. But it did. Like I am actually, like I can actually say that I'm clean off of those drugs. So now it's just to get me off of those, the pharmaceuticals, but that's where I'm at. And that's, yeah.
That's so wonderful to hear, Cheryl. And Kat, thank you for sharing those experiences of yours. I know, Dr. Rook, you had some clinical insights that you also wanted to discuss with the group. Did you want to dive into a couple of those now?
Yes, sure. And I'll just be, cautious of the time here too. I'm so grateful for everyone's input on this, and I hope I can add a little. I just want to say that I think primary care providers in rural situations are so well positioned to do this. Your local resources and availability, but also acknowledging that can feel a little bit isolating and stressful, especially if you may feel that all the people you work with are on the same page. And just to remind you that, you are part of a bigger community of people working with this very challenging situation. And, these services like the 24/7 and the race line can be really fantastic. Even if you think, but you just want a little bit of reassurance, please go ahead and use them. Also, I know that the access to things like psychiatry and psychosocial supports can be so limited. So perhaps calling and working with your community members just to understand what's out there a little bit more. I know we're so busy sometimes, checking in can be really helpful. I think too that it's so rewarding working with these tools because clients are quite happy to give this a try. It's on a lot of people's minds. And when you are really open with, trying to find something that works and having options like, giving Dexedrine or dextroamphetamine a try. And if that doesn't work even at a high dose, then maybe switching. It's just much easier to, talk about where we're going and how things are going to work, especially if you know what kind of symptoms you're trying to target, what kind of outcome you're looking for. Next slide, please. I'd just like to talk about schizophrenia and stimulant use disorder and history of psychosis. I personally find it's very common that clients have had these experiences, and the current guidelines say use extreme caution, and I'm not too sure how to interpret that because I know everyone takes a lot of caution around the medications they prescribe, and what we're dealing with is something that's really can be toxic to the mental health. And crystal meth releases an incredible amount of dopamine, and if we can reduce someone's reliance on it even by a little bit, that could be quite beneficial. And not everyone's going to fully agree, but that's where I've landed. And so far it's been helping. And but establishing those goals up front about like what it looks like if things are improving is really important. And generally, I find clients want to be on fewest medications possible. So if you say, why prescribe something if it's not actually doing anything, most people can get behind that. And it makes the discussions about maybe discontinuing a little bit easier. And especially because I'm a virtual program, I always seek permission to work with mental health care teams and primary care providers. Sometimes clients don't want me to speak to them because of safety or fear of stigma, and that's okay as well. And we have to respect that. Also, I think our panelists would agree that it's not going to be the same as cocaine, crack, or crystal meth. It's going to be a different feeling. And so understanding that, it's going to feel different when you're taking this. Hopefully it's helpful, but if that's what someone's looking for, it may not be the right thing. But if they really want to try it, again, I would say, all right, let's give it a try, just with some understanding about what benefit looks like. And next slide, please. Commonly, as it's been talked about, opioid use and crystal meth use come together. One thing I ask in my assessments are they actually used together? Because I found many clients find that the crystal meth is there to support the opioid use. And if that is the case, then sometimes we work a little bit harder on the opioid use to see if the crystal meth use goes down as well. Or sometimes it's separate, and clients might feel that they want specific medications to target that. And then this is something you're reassessing and reevaluating frequently. Next slide, please. And then there's the ADHD in the context of stimulant use disorder. Strattera or atomoxetine has often been cited as the medication of choice, but it is not a full psychostimulant. And the psychostimulants have the most evidence to support treating ADHD. Also, atomoxetine is very difficult to get approval for. So generally using psychostimulants, I think in this context I would encourage you to give it a try. We're often dispensing daily to start, but if that becomes a problem, like getting to the pharmacy, just plan with your client what an alternative plan would be. Like maybe it's dispensing every 2 days, maybe Monday, Wednesday, and Friday, or carries on the weekend, and maybe advancing that as you see fit. It's hard to say which medication someone will benefit more from, the dextrogen or methylphenidate. So I just leave it open to choice. And I'll just pause there. Thanks. I just hope that those are a little bit of practical advice about how I'm doing this work in my virtual care and in my community-based practice.
Thank you, Dr. Brooke, for sharing
Eddie,
that.
Sorry, I was just going to say that I would echo. I do the exact same thing in an urban setting. So I think that those are really good pearls to keep in mind. But again, I can't stress more than anything. It's regular. It's close follow up. It's that close relationship that I'm hearing from Cheryl and Kat, and it's regularly checking in and being willing to adjust, and it's a collaborative enterprise.
Can I just throw in a note, and just focusing on the rural remote settings? It is really difficult to go in daily, twice or every second day, or 3 times a week. I think if that is what it looks like to prescribe somebody something, it is really important to have to know that they have a plan A, B, and C to get there and rides set up for them, because if not, that's a setup for failure. So I also think that it is really important that if you're, wanting somebody if we're trying to help somebody, and that is the ultimate challenge, is getting from A to B to get their prescription, that, being a bit flexible on what that looks like, and trusting, and Cheryl's right. Like, some people just need to have it explained to them what they're going to expect, what they might expect, how it works, why they think this might work for them. Some people just need that to understand that, okay, I can't just go and take 10 methylphenidine and go get high, because it's not going to, get me more high. It can put me in jeopardy, right? And like, just really understanding that. But I just really want to stress that rural remote settings, super challenging to get your prescriptions.
I agree with you. And sometimes when I follow up, say the next week, and I see that someone's only been in like once or twice, I say, has it been hard to get to the pharmacy? Like, what would be easier? Like, what if it was just 2 or 3 times a week? And often that does the trick. If someone is out of town, you've got to make those arrangements. How are they going to get those? How often can someone come in? Is there a nursing station that could potentially hold on to them to make it easier? Can a peer network support getting the medications? That's been a useful way to make sure people get meds as well.
Thanks.
That's so excellent. I really just want to take a moment to thank everyone. We're kind of rounding out the hour here. So thank all of our speakers for being here and to thank our participants. We had some questions submit with the registration process, and I think I'm just sifting through those questions. A lot of the content was discussed today. I'll acknowledge we didn't really dive too much into urine drug screening, and someone did ask about the value of urine drug screening and providing care for someone with living with stimulant use disorder. I will put in a plug. We do have an upcoming BC Echo session on June 23rd at 12 p.m. where we'll be doing a specific dive with ordering and interpreting urine drug screens. It's specifically for the context of opioid use disorder, but if you want to join us for that, we can have a more fulsome conversation around urine drug screening.
Well, if I can answer that in like 20 seconds, Rebecca, is that
Sure,
I'd say
go
that,
ahead. Yeah.
you know, I think the utility of urine drug screens in medicine as a whole is far less than it's been previously made out to be. But particularly for people who use stimulants, I'd say the utility is very low because, and again, Sherelle and Kat, I'll welcome your thoughts, but people use stimulants in very different patterns, and it's not necessarily daily. And so just because somebody's urine is negative, it's not a reliable marker that they're not using. And similarly, I think we've touched on this many times, that abstinence is not necessarily everyone's goal. And so positive urine drug screen isn't necessarily all that meaningful, not to mention the fact that both dexedrine as well as methylphenidate, or dexedrine especially, is likely will give you a positive urine drug screen if you're taking a medication. So to me, the biggest utility for urine drug screen in somebody who's using primarily stimulants is to figure out if they're inadvertently being exposed to anything else. Is there any fentanyl in their stimulants? Is there benzos there? You know, do we need to have another discussion on just safety as a whole?
Great. Thanks so much for adding that very quickly, Paxton. And with that, I will close off our webinar for today. We are going to be sending around an evaluation link for today's webinar, so please let us know what you thought. And also, Nicole is going to be putting this in the chat. If you want to just click on it now and complete it, you're welcome to do that as well. But again, I just want to extend the most sincere thank you and gratitude for our speakers today, Dr. Eddie Rook, Sherelle Leckie, and Kat Cadeau, as well as Dr. Bach. Thank you. It was really wonderful even for me to hear your experiences. I learned a lot as well. So thanks so much again for joining us, and it's greatly appreciated. Okay, and we'll go ahead and end the webinar. Thanks everyone. Bye.